Hello, everyone. My name is Theresa Toczylowski, and today I'll be presenting my lecture, The Wonderful Wizard of Oz, a PT Peeks Behind the Curtain. And so we want to thank the Shrier family for their generous gift, and we're grateful for their support and belief in our mission. This is the part they told me to pause at, so you can all get your credits. So I will take extra time to pause to get that code 43 Dean. Okay, so disclosures. No one has anything to disclose. This slide reminded me that I am the only one without a PhD, so please be kind. I was like, oh, this is good to know. Again, Mary, you're the only reason I'm here.
Glad to see you, Theresa.
Yeah, great. Glad to see you, Mary. So some objectives. We're going to go over the importance of outcome measures in stroke rehabilitation, and also the idea of actually focusing on upper versus lower extremity function. We're going to be looking into reliability and validity of these measures. And I also want to introduce everyone to PHOTO, which stands for Focus on Therapeutic Outcomes, which is a web-based computer system that we utilize in outpatient currently, and the data that we get from that. So, thank you so much for having me today, as I said. To be honest, I am quite intimidated. Not a PhD, and I kind of feel like a stranger in a strange land. That's the Wizard of Oz thing. Sort of like I got pulled up into a tornado, conked up in the head, and woke up into a wonderful world that I'm quite confused by. So bear with me and my rudimentary understanding of statistics. And then this morning, as I tend to do, I'm washing my hair and I start thinking, you know, I identified with Dorothy because she's young and cute, but maybe now I'm more like Toto, like an old dog who gets lost easily. And like, I can't keep assuming that I'm the young blonde pretty thing, but anyway, that's just an age joke for those who understand. So a little bit about myself. I'm a physical therapist by trade. I graduated from the University of Science, which was also Philadelphia College of Pharmacy and Science in 2000. And my whole career pretty much has been at Moss. I was a student, my last clinical appeal, and then I got a job at Willowcrest in the skilled nursing facility. Then I moved over to acute rehabilitation. Then I did a stint on outpatient TBI, and then barring a little side trip to Chicago, I came back and started working in outpatient here at Elkins Park. And I've been the clinical manager since 2022. So to start, let's do a little story, because I think it speaks a lot to assumptions and first impressions, not only as a staff member, but for a patient's point of view. So I started in 2009 in the outpatient department. And as you all know, when you first start a job, there are many things that you need to be oriented to. And sometimes they remember to orient you, and sometimes it kind of flies under the radar. And it becomes one of those things that eventually you get in trouble for not doing, and then they realize that they never told you. So my boss sat me down and said, Theresa, we're concerned because you're not using PHOTO. And I said, okay, I'm really sorry, I don't know what PHOTO is. And he's like, just talk to one of your coworkers. And I said, okay. So I talked to my coworker, and she goes, it's something over there. You got to sit the patient down. They do a photo. And I said, well, what's it for? And she's like, we're not really sure, but you can use my login. And I said, all right, well, is it a test? Is it collecting information? She's like, I don't know. It's for the government. Cool. So I start telling my patients, I'm really sorry. I need you to go sit over there and get a photo for the government. So as you can imagine, I did not have good rates. People did not want to do photo. I had the highest rate of refuses to participate because I had no idea and the patient had no idea. And then I noticed that people were like circling around the kiosk because they thought the government was watching them, which was a whole nother problem. So really what this speaks to is introduction of a tool, letting someone know what it's meant for, what you're trying to capture from it. And a lot of patients find this in real life, you know, they get in a doctor's office, maybe 5 to 10 minutes with the doctor. And if they're filling out all these forms and no one's telling them what it's for, or that anyone's even gonna follow back up of what it means, then it becomes less important to the patient if they don't think that it's important to you. So another thing that, since I've become clinical manager, I get to have some unique opportunities. And this year we are merging with McGee in the physical therapy neurological fellowship or residency program. And so I was asked to join a group of other managers to make sure that the applicants were a good fit for our system. And so we asked the same questions, you know, where do you see yourself in 5 years? Why did you become a therapist? What are your goals? And Marcia Moore, who many of you might know, has this awesome question, and she goes, what's your favorite outcome measure? And it's like a fun party game. And you can learn a lot about a therapist based upon what their favorite outcome measure is. So for me, it's photo, but barring access to photo, it would be the PSFS. It's very individualized to patients. You can monitor it and check it, but you know, it's fun party game if you like to ask around of what people's favorite outcome measure is. And so when we talk about outcome measures, there's two groups. We have clinician reported outcome measures, which is where a practitioner is making a judgment on a certain variable or some type of quality that you're trying to capture based upon the therapist's take on it. And then there's patient-reported outcome measures where the person is giving you their perspective of where they think they are on that. And so this is where these concepts get a little bit tricky because measurement in its purest form is just turning everything into math. So when you think about the idea of function or pain, we're taking this very abstract human component and trying to put numbers to it. But if you do that, this is where it kind of gets, like, math always has a right answer, and there are a lot of things that you can do to manipulate numbers. And so you take these very unique abstract concepts and you can do mathematical things with them. So that's the level of what I believe statistics to be, that there are these concepts that you can gather and you can do math and make more sense out of them. So stroke rehabilitation, from the CDC, approximately every 40 seconds, someone experiences a stroke. And in fact, over this next hour of lecture, about 20 people will die from a stroke in America. From our perspective on outpatient in physical therapy here at Moss, the majority of our patients with a neurological deficit do suffer from stroke. So that's our largest neurological population. So some stroke outcome measures, some of these are specific to actual stroke, and some are just used and they are asked general questions about the health of the individual. So some examples of clinician reported outcome measures would be something like the Fugl-Meyer assessment, the postural assessment scale for stroke patients or PASS, the functional independence measure or FIM, and then some patient reported outcome measures would be something like the SF-36, which actually, when photo was first started, that's what they based part of their components off of. The NeuroQual and the PROMIS tools, and then the stroke impact scale. So just to get an idea, I just kind of put this up here, a screenshot, just some of the things that you would capture through a clinician reported outcome measure, such as in the upper extremity for stroke, reflex activity, and then all of these you put a number to. So none versus can be elicited, volitional movement, none, partial, full. And within there, you know, there should be some kind of instructions to say what differentiates partial from full, because these things can get vague and you want to make sure that you're being consistent. So then from the patient reported outcome, something like the stroke impact scale, uses something like a Likert scale of something to like a lot of strength is a 5, you're giving that number, to no strength at all from the patient's perspective. So this is just another example. Okay, so here come the angry trees. So for anyone who's not a statistician, this might get a little scary. This is what I understand this to be. So item response theory is in essence a way to measure these abstract concepts. There's classic test theory, which really continues to check on the reliability of a certain variable. And then item response theory conceptually helps me if I see a graph. So if you are trying to measure something on the x-axis, like let's say function, you're assuming that there's some type of scale of function that goes from low to high. And then the y-axis is probability. So from 0, meaning no likely, unlikely at all, to very certainly probability, 0 to 1. And along there, you can map people's answers to questions or items, which is what they call. And then having this curve, you can do these mathematical equations to figure out more about what you're trying to ask. That's the very basic. If you are interested in learning more about item response theory, I would very much recommend Karen Cook, who's another author on this paper. She does a YouTube series on it and makes it a lot more understandable, and I highly recommend it. But because of the difference between item response theory gives us a lot more ability to look at things deeper. So back to photo. So photo utilizes item response theory, and they started in 1992, and it was actually a group of private care clinics that wanted to start collecting data about function, which is what they felt in their practices they were trying to make the most change to. So these patients with orthopedic injuries would come to them, and they were really trying to improve their function. And they wanted to make a language that was consistent that they could start to capture. So they did start with paper and pencil. And then as they continued to gather more data, they started collecting it electronically. And then they were able to utilize the item response theory concepts to develop the CAT, which is computer adaptive testing. And computer adaptive testing is basically the math of IRT in real time. One of the most strongest aspects of utilizing photo is that they've been collecting this data for so long that to date they have 47,600,000 assessments from patients. So that's such a large N and so much data that you're able to compare. And as a clinic or a network, we started collecting data with them in 2008. So like I said, computer adaptive testing is basically item response theory in practice. It's the math behind IRT. And it's really looking at the probability of an inherent trait, or that x-axis of whatever it is. So for photo, it's function. So it's the probability that a person's going to answer a certain way to a certain question on that line. And the reason why computer adaptive testing is so important to us in the clinic is that it's efficient. So instead of having to ask 25 questions about function, we can narrow that down to 5 questions. And with the same probability, place that person on a functional scale. So this is where Merritt came in and asked. So because I was working with photo, so that was the other thing. When I realized I didn't know anything about photo and started asking more questions, the problem with asking questions in the clinic is that then it becomes an opportunity. And so when people couldn't give me the answers that I wanted, I became in charge of it. So I started collecting just in-house data, like how often were we using it? Number one, we were paying for it. I was like, we're paying for something the government is getting photos for? Like, this isn't making any sense. And so finally, when I understood what we were doing, I said, we need to get the word out. We need to let people know why we're utilizing this. We need to let patients know why. We need to let clinicians know why. A lot of problems that we were having was that we were getting an initial survey, but we weren't getting any follow-up. So we never closed the episode. And so we had no data. So I think when we started as a network, after using it for 3 years, we had a 14% completion rate, which is abysmal. Yeah. And when we looked at how much we were spending on it, that was a quick fix. So we started setting goals for ourselves. And within a year, we were back up to like 85% completion rate. And when we had that data, there's so many, I guess part of what I should talk about too in the clinic is that when you implement these things, if you don't give people the why behind it, there's no buy-in. When you give people the why behind it and you help them to understand the utility of it and what you can capture from it, it makes sense to use it. Otherwise, it's just another piece of have to do on a person's list. We also found that when we engaged patients, we got better results because they knew why they were answering it. This wasn't a government-funded, endeavor to capture their picture. But the clinician was really going to utilize what the patient had said to draw up treatment goals and to assess to make sure that we were all on the right track. So in participating with photo, as I said, historically, they were capturing a lot of orthopedic data. So a lot of their, they were taking things like the dash, components of the dash and utilizing that in surveys. But from a Moss rehab perspective, we have a large population that we just couldn't use. There was no appropriate survey. There was like a general medical surgical one that didn't really capture what we felt were the challenges of our patients with stroke. And so we continued to say like, hey, we are spending a lot of money with you guys, and we have a huge population that we could utilize this more. Help us, help you, you help us. And so they got together a team of therapists and stroke clinicians, experts in the field, and started to say, okay, what would our database look like if we were to create a survey, a patient-reported outcome that utilized item response theory? So that was kind of where we have a lot of patient-reported outcome measures. We have ones that are general medical. We have some that are like the stroke impact score, which is patient-reported and it is stroke-specific, but it doesn't utilize item response theory. And so we were trying to gather something into to create something that incorporated those three things. So we had to start with a pretty large item bank or potential candidate bank of functional questions that were appropriate to ask someone who had experienced a stroke. And so we had a list of upper extremity candidate questions and we had lower extremity candidate questions. And through a lot of expert panel discussions, emails, back and forth discussions of trying to get the most appropriate questions for the candidate bank. And so from a total of 56 potential stroke upper extremity questions, 43 potential stroke lower extremity questions, making sure that the average reading level was at 6th grade. Unfortunately, we could not get, so you see the stroke lower reading level is 3rd grade. It's 6.6 grade for stroke upper, and it has to do with having to talk about the arm that's affected by the stroke. And it was that wording that made that a little bit more complex. So we started capturing data from a potential of 2017 patients with a stroke involving upper extremity disability, and then 2,107 patients with stroke involving lower extremity involvement. The 3 STEM items for upper extremity, the STEM is just the start of the question. So how hard is it for you because of your stroke? For your upper extremity, and then with both hands were the 3 stems for stroke upper. And then for the lower extremity, it was how difficult is it for you because of your stroke? I don't know how well this is gonna come up, probably not so great. But some of the questions that we were able to finalize on, I think the midpoint for upper extremity was how difficult is it for you to pick up coins from a table for the hemiplegic arm? And then, for the lower extremity, how difficult is it for you to get up, off of the toilet? Would be like a mid-range question, because again, when you're utilizing item response theory, you are assuming that each question is gonna have a difficulty along that scale. So you would have someone who's really low functioning would have less, probability of saying that I don't have any difficulty getting up and off of the toilet. And then you follow that curve along there. Data analysis. Here are the flying monkeys. So a lot of this is generated from Daniel Deutscher. He's the lead and author on this. A lot of it utilized mathematical equipment and software to determine if the numbers were reliable, if they met the validity, and I would need a whole another degree to explain that properly. But if you have questions, I could do my best to find the answer for you. So what did our results found? So we found that it supported unidimensionality, which is basically that what we were trying to uncover, which was patient function, was reliable or able to be learned from that scale. It supported fit to the IRT, meaning that curve that we generated, that the questions within a certain mathematical error stayed along that curve. The reliability estimates were greater than 0.93, which in general you wanted it to be above 0.9. No items demonstrated differential item functioning. So from what I can understand, that is the inherent qualities of a population. Like, let's make this really easy. We didn't find any questions that women answered differently than men, or people who had an early stroke answered different than someone who had a chronic stroke. That would be something that picks up another variable that you would have to track. We had the hypothesis that patients who were male, who were younger, had lower chronicity and less comorbidities, that they would do better. And that's what the data showed. There were negligible floor and acceptable ceiling effects. And so floor and ceiling are really the end points of that function scale. So someone who is really low functioning, those questions, that they're in acceptable range, but when we get to that part about things that could be done better, I'll discuss more about those items in the low range and the really high range. And in general, for efficiency of the outcome measure, it took about 6 questions to determine where they were on that scale for the upper extremity and about 5.5 questions for the stroke lower extremity. So let's see what this looks like in real time. What would you come across in the clinic? And so when we're collecting the data, we look at the patient's birth date, their age, their sex, and then we're going to start a new episode. So at this point, your clinician will go down, choose themselves, and then we have certain care types that are going to pull up a different survey. So for now, we're going to look at neurological. And we'll go to stroke upper. They also want to know the patient's insurance, because we found that that will give us a different type of risk adjustment. The other thing that's nice is that they do give us the ability to add secondary measures if there's something else that you want to track. And so you can add those. But for today, we're just going to stick with the stroke upper extremity. If the person can utilize email, you can just send them a survey. But majority of the time, we're just in the clinic and we're handing them an iPad or they're doing it on a desktop. So this is what, just trying to open this up a bit. Okay. There we go. And then you can increase so this is generally what your patient is gonna see. Thank you for choosing to complete this assessment. These questions help with your clinician create and monitor and adjust your treatment over time. There's no wrong answers, and we want to know what you think. When answering the questions, remember the following points. This is specific to the problem that you're receiving treatment for. This is how you've been over the last couple days. If they don't exactly apply to you, you're just gonna use your best guess effort. And then they're gonna ask things that you can and can't do. And the reason why we have to ask things that we know they can't do is for that ceiling and that floor effect. So if you have not done this activity, just what you think fits best. Using your hand that was affected by the stroke, are you able to pick up coins from a table? So as I said, that was that midpoint question. And so I'm gonna choose somebody who's gonna say with some difficulty for everything. Using your hand that was affected by the stroke, are you able to place a 1 pound of soup on a shelf at shoulder height with some difficulty? Using your hand that was affected by the stroke, are you able to comb or brush your hair with some difficulty? Using your hand that was affected by the stroke, are you able to open a refrigerator door with some difficulty? Using your hand that was affected by the stroke, are you able to wash your face with some difficulty? So at that point, that's about 5 questions. It's determined where the person is on that scale of 0 to 100, which is just an arbitrary scale of function from low functioning to high functioning. Now it's going to ask some background questions because we're also in the process of doing this, collecting data about prediction, about what we think the person can achieve during that time. So prior exercise, did they work out prior to? We're going to say seldom or none. Have they ever received treatment? No. Are you taking prescription medicine? Yes. How many surgeries have you had for this problem? None. How many days ago? We'll say they're in the 22 and 90. And then here's where they would add their previous comorbidities. So arthritis, stroke or TIA, and hypertension. You'd also look at diabetes, because some of these things that are more likely. And we'll say anxiety. Then it's also going to do a BMI check. Okay, and then it gives you preliminary results. So your patient would see that today they scored 50 on that arbitrary scale of function, 0 to 100. And that typically patients like them, after they're done therapy, can achieve 11 points greater on that scale, and they would be a 61. What happens at this point is that the survey prints out automatically in the clinic, and the therapist will have access to see how the patient responded, what the functional score is today, and then what the predicted score is to be. If we had, like Epic is integrated, and they can capture all that data and just pull it right into the chart automatically, which is nice. Cerner can do that, but we don't have that package. So I am hopeful that eventually when we move to Epic, we'll be able to have all this data. We'll leave it that way. Now, see if we can get back. Okay, so here's where I think the power of photo really is. It collects all the data for us over a time. So right now, we're looking at the last 3 months for Q1 for all of the outpatient centers within Moss Rehab. And they give us a scorecard. And so if we look here for our orthopedic patients, we did 2,379 intakes, and we closed 3,348 surveys. Yep, that would be my department. Cool. All right. Hope they're on that. And so what they found was that our predicted change over all of the orthopedic cases that we did was 16.07, and our actual number was 13.97. So we are trending below what the expected is for orthopedic functional. Our predicted visit score was 12.40, but we're seeing people within 11.69. So if you start to look at this data, you could start to ask, well, you know, it seems like we're keeping people for less time. You know, if we kept them an extra visit, would we capture more scores? But also, as you all know, you can make a lot of wrong assumptions with data, right? So the majority, when I do a deep dive into the data, I actually know that we have higher patients with higher comorbidities, and that a lot of them are medically unstable and they drop out. So a PT might do an intake, they do a check-in survey, things aren't going well, and they send them back to their doctor. Well, we have those 2 points of measurement and they weren't great because the person wasn't medically stable and we sent them out. And so that data gets captured. But I can start to follow and investigate more trends that way. So if we look down here for stroke lower extremity, loss rehab is doing about a point better than expected. And then for stroke upper, we are about 2 points better, if I'm drawing that line. Oh, 3 points, 3 to 4 points. So this is just a nice, easy way to capture data. I don't have to ask somebody to run it for me. If I want to go deeper, there are ways that I can get the raw data. Actually, one of the doctors, Dr. Miragasemi, was interested in seeing what Photo has found about certain surgical interventions that have happened here. So we've been requesting raw data from Photo, and that's been helpful. So there's just a lot of things that we can get from the outcomes that way. The other thing that we gather is satisfaction. So we can find out, you know, how we're doing with how happy patients are with our service, with the ease of getting appointments, with their input into setting goals, which is also important to us. So, okay, I'm done all that part. Okay, so there's no place like home. We continue to collect data, as I showed you, for stroke upper, for stroke lower. As we collect more data over time, we can start to look at something like longitudinal validity or responsiveness of change over a time period. We can also look at those extreme scores. So the people who are really low level functioning versus the people who are really high functioning. We probably don't have enough appropriate questions right now in the database for those patients. And so we should start to include some lower functioning questions and some higher functioning questions so that we don't lose any specific details from those groups. Also looking at different languages, Spanish would be the second most popular language, and we would want to gain more information from those patients. Another thing we can look at too is, you know, we're assuming that the patient, when they take this survey, that the therapist has deemed them appropriate to answer these questions. But we could also utilize a recorder or a proxy. A recorder just writing down what the person responds, and then a proxy would be most ideally a caregiver who lives with them 24/7 who can answer reliably for them. It has been shown that proxies tend to underestimate the patient's ability, while patients usually overestimate. Okay, so even though there's no place like home, I can't believe I'd be crazy enough to start asking questions, but maybe this is why you're all here. Because I'm gonna ask the question and maybe it spurs you guys to be like, woohoo, yeah, let's look into this. So I feel like over the years, I've done a lot of education with Photo, the good, the bad, the ugly. If you are your Photo person at a clinic, you really need a support group. And I find that in the Photo community. I go to the conference every year and it's a bunch of beat up PTs who are like, everybody hates me, nobody wants to collect data. But there's power in that and learning why people are resistant to this. And the problems, there is no perfect outcome measure. And if there was, we would all be using it. They all have their strengths and weaknesses. So I started to get thinking of like, if you could have a patient reported outcome that also tracked clinician report at the same time, there's gotta be so much data in that, right? Like if you had an outcome measure that combined a clinician's perspective with the patient's perspective. And so I started looking into it, and there are people who are starting to look at this. So I found this article called Comparison of Patient and Clinician Reported Outcome Measures in Lower Back Pain Rehab, Introducing a New Integrated Performance Measure. And so maybe this is the future where you get input from the clinician and you get input from the patient, and we can find better ways to track outcomes. So thank you very much. Does anybody have any questions? And thank you to everybody who's online. Any questions? Yes, Dr. White.
Does photo give you any insight when you compare people who did better than expected and worse into any of the reasons, or you have to go digging through whatever sources you have ideas for that elsewhere?
So what we have is they collect a whole bunch of data on risk adjustment. And you can look at all of the kind of the factors that make up your population. So they'll break it down into the insurance that they have. They break it into the chronicity, sex. If you really have a topic that you're like, whoa, what if this is what's really affecting it? You can contact them for the raw data to try to see it.
Well, I mean, I guess I was really getting at, the ultimate purpose of this is to help judge how good we are
Right.
after controlling for insurance.
Yeah.
So is there anything in photo that will allow you to look at what it means do differently for somebody who had a good outcome versus, or you have to do chart reviews or some other?
That would probably be other information, because you don't really put a lot about what the interventions that we're doing into the system. We would have to, which we eventually could do, if we get to an electronic medical record that we could track that, like Epic, start to say, like we're doing with the upstairs, right? Certain factors in treatment care, how are they affecting our outcomes? So we could use photo as the measure to see those numbers and then look at what we're doing interventionally. Great question. Yes.
I was just curious, you mentioned in the presentation a couple of times that there are barriers to adoption and to clinicians implementing this, and there might be some resistance from patients. Like, in your experience, what are some of the factors that determine like how enthusiastic clinicians are about using this and whether patients agree to participate in that?
I have to say, a lot of times it has to do with the openness of the clinician. So I don't want to say it's age, because it's not like older therapists are like, no, I don't want to use photo. But maybe it's more practice pattern. And usually the people who are in the clinic and have more experience have a lot more responsibilities on them. So when you bring them another thing that they have to do, it's like, so unless you're showing them that this is actually going to make collecting data easier, it probably is just going to be another thing to do. So you have to show the value. I could ask Kelsey. She is one of our photo users and more of a novice clinician. So what do you feel is restrictive in the clinic?
So it definitely takes time getting used to it and kind of incorporating it into your evaluation, like making sure that you're leaving time. And honestly, it really is on us as clinicians to get the patient to buy in. Like if I just hand them an iPad and be like, my boss makes me give this to you, just fill it out really quick, answer however, they're not gonna answer very well, reliably, anything like that. But if I really sit down, and how I usually set it up for patients is I say, as we go along, we're gonna be tracking your progress. And there's gonna be things that I'm gonna track with measurements and scores and how I think you're doing, but it also matters how you think you're doing. Like, how is your function at home? Is what we're doing in the clinic actually matching up with, like, are you seeing changes there? So I feel like when I kind of match it up with that, explaining to them, like, I care about what I'm seeing, but I also care about what you're seeing at home, I feel like they have a lot more buy-in.
And that really speaks a lot to the therapeutic relationship, which is another factor that we're trying to determine if that makes, there's a lot of research now about how well the person has a relationship with their therapist and whether they trust them to get the job done. So having these conversations of saying, like, your point of view matters to me too, and here's an objective way to do it. And here's, I've had patients where, here's a primary complaint. I did everything right, the patient says they're better, all their numbers are better, and they're worse on photo. And it's like, everybody likes to bring me that, like, I fooled your system. And it's patient perception. I don't know that the person read every question. I also don't know if we practice 4-inch steps here, but at home they have 10-inch steps that they can't get up. And so you wouldn't know that unless you had feedback. So photo also gives you the opportunity to kind of right the ship and say, hey, I thought we did really good on steps last week. You're saying it's still like pretty hard for you to do them. Can you explain why? And then you can capture all kinds of things you didn't even know to ask. Well, these steps are easy. I can do that with my eyes closed, but at home I can't see and I have this. So it does allow you, if you use it, to help improve the goal of where you're trying to get to.
I feel like you also, we get the report afterwards, and it's also on the therapist to actually look at it instead of just throwing it in the patient's file. So like maybe you have someone who comes in who they do like very little ambulation at home, but then you look at the survey and they wrote that they have no problem walking 1 block in the community, which happens a lot.
Yeah.
So then for the next time they fill it out, either maybe I go to Theresa and I say, this person it's not applicable to them, I don't think they'll do well. She's able to delete that original survey. Or I wait until the next time and I kind of sit down and like question by question go through it with them, say like, let's actually talk about like, when you do it here, how do you feel? And I can give them a little bit more help.
Yeah, and so these are, when you look at, I wish sometimes that rehab was like medicine and that if you give 2 doses and then you see this change, but people are not like that. And the environment has a lot to do with it. The people's mood has a lot to do with it on that day. So these are all areas of error that we try to minimize. But at the same time, we can only do so much. So at the very least, utilize the feedback. So there will be times that people will say, oh, I was late to the eval, so I just gave them a photo and then I did the eval. And all of the questions will be inappropriately answered. And I go, okay, well, that told you a lot about their cognition and their self-awareness, so they're not appropriate for photo. You might want to use a recorder or a proxy to have that some type of data capture, and we can do that and then do it that way. Yes.
So I have a question specifically about how you got to standardize the stroke questions because amputation gets mixed in with orthopedics.
Yeah.
And so we're comparing people that had ankle fractures to people who don't have legs and
Right.
they're all basically together.
Yeah.
And so what they keep telling me is keep entering the data because it'll eventually, it'll help them get their scores, but it's still really difficult to get clinicians to buy in when they're saying I'm compared to an ankle fracture or above the knee is somebody with a knee replacement, like you're.
Yeah, and so that is,
I have
yeah,
met with them multiple times.
Right.
Even just to get them to put the diagnosis in there.
Yep.
But now that the diagnosis, they don't have bilaterals, but we're expected to put bilaterals in there, like, it's just for me personally, I really have a hard time motivating the therapist to keep at it.
Mhm.
But also, I'm not really sure if I'm compared to people, but I'm not sure the group I'm compared to.
Right. And those are all valid questions. The problem, and again, this is another weakness, is that it's a privately owned company, right? So I only have so much that I can, push. One thing that's helpful is sometimes finding out what other health networks utilize photo and finding the person on that team who also has your vision of what you want it to be and getting the data that way. Sometimes, like they went through a restructuring that they were bought by Net Health So the last conference I went to, it was like all about wound care, and I'm like, oh Lord, I hope we don't lose track of this, but finding the right people, and then sometimes you can request raw data, that's another way to do it. But there are definitely limitations. The other thing that kind of came across, like, there is promise, I haven't done I have not done a deep dive into promise if there is amputee specific, and then what we can do with that data.
So promise is more to evaluate your satisfaction with the device, not necessarily with your therapy.
Right.
So it's more about, is the device comfortable, does it function? Like, it's more about the prosthetic provider than the therapy.
So, I mean, I've listened to many podcasts on patient-reported outcomes, which is kind of embarrassing, but they are out there. And most of them will tell you, don't try to make your own patient-reported outcome, but I think we should. I think that why not? Like, if they're not listening, it's just every time they're like, no, don't do it, don't do it. I'm like, why not? If other people can do it, why can't we start to collect the data and find the right people? Come on. We got a whole half of the room here. These guys, you gotta know. Like, I'm not the person, but I could help with some stuff, right? There's gotta be somebody out there who will start to, it's like, you can gather all the data and then, I think it's just
But
fine.
for the stroke,
Yeah.
you came together, went to photo and said.
No. Photo came to me after I pestered. And we were spending a lot of money. And it was right place, right time. Like, I've asked, like, I'm dying for I shouldn't be so extreme, but I am very eager to have one for a spinal cord injury. I can't give photo to patients with spinal cord injury when it says, how hard is it for you to walk? No, I'm not gonna ask that. Like, day one, let's bring up a touchy subject. So there are ways to do it. It's finding the right people. One of the people who used to work here was just let go. Like, that's another problem with that. So more questions, more opportunities when you don't know the answer. Does anybody else have any questions? Anybody online? Sorry.
Workers' comments,
Okay.
you can do it yourself, you just
Yes, and that is difficult. If the person can't answer reliably, it's not really appropriate to use a patient-reported outcome measure, and that's okay. We can't capture all the time. Now, it is difficult when you are looking at a neurological population where it's more likely to have issues with cognition. But again, there is the email feature, so you could identify someone in that person's family that you could email. So even if they're not there, you could start, like emailing them the survey to have them respond. My experience as an outpatient, no sense that it was optional to complete the measure. I also found I resented the time taking from beginning to end to do the photo. So again, I'm sorry that you had that experience. I would tell your therapist to email it to you, so that way you wouldn't have to utilize your time in the clinic. All right, thanks, everybody. Thanks for having me.